Good afternoon, dear colleagues. It's a great pleasure and an honor to be here in one of maybe the biggest cardiology congress in the world. My name is Emin Evren Ozcan. I'm from Turkey, Izmir. This is the place I come from, very far. My topic is atypical accessory pathways. Actually, when you start dealing with the accessory pathways, there are many atypical patterns, but today we will talk about accessory pathways which have AV nodal conduction properties. Actually, they have real nodal histological patterns, and they behave different than the other accessory pathways. The story begins during the embryonic stage. The primary ring, which is responsible for the AV node and conduction system development, incorporates with the tricuspid ring and travels together. That explains why almost always this kind of accessory pathways are right-sided. But there are many kind of accessory pathways who have this AV nodal conduction properties. The well-known are like atriofascicular accessory pathways from atrium to the fascicles of the right bundle. There are also some AV nodal conducted accessory pathways with long conduction or like short, close to the base of the right ventricle. There are also some other kinds like nodoventricular and nodofascicular accessory pathway. Actually, these are the accessory pathways first described by Professor Mahai. But usually nowadays we see more often the atriofascicular accessory pathways, and there is a terminology. This terminology usually used for the atriofascicular accessory pathways. There are also some fasciculoventricular accessory pathways which cause pre-excitation in the ECG, but never cause arrhythmia. So these are AV nodal conducting accessory pathways, but they have no retrograde conduction. When you pace from the ventricle and you do EP study, you will observe AV nodal like concentric decremental retrograde conduction through the AV node, because they don't conduct retrogradely, they only conduct anterogradely. So that's why they only cause antidromic tachycardia with white QRS tachycardia. This white QRS tachycardia morphology is like left bundle branch block morphology. But during sinus rhythm, we usually don't see any sign of pre-excitation because they usually decrement slower than the AV node. But there are some clues if we check the ECG in lateral electrodes. There you cannot see these septal Q waves. Also RS pattern in lead 3 is a suspicious sign for atriofascicular accessory pathways. So when you start EP study and do the baseline measurements, you cannot see the pre-excitation, normal AH and HV interval. You can see, as you can see here. And if you pace with shorter coupling intervals from the atrium, especially from the high right atrium, you can see the AH increase and HV decrementation, and also pre-excitation on surface ECG. And also you can see the same response with incremental atrial pacing, as you here see. When you pace faster, you can see the pre-excitation, HV decrementation, and also left bundle branch block morphology, QRS. And then usually tachycardia start with these maneuvers. So when you can see the typical short HV, left bundle branch block morphology tachycardia in usually for atriovascular tachycardias. As you see here, is the first when the tachycardia starts. This is very important. This is also a sign that this RV apical ventricular signals are earlier than the his region, the baseline, because it's conducting to the apical side, and the retrograde conduction is through the AB node. If we see this kind of wide QRS tachycardias, we need to do some differential diagnostic maneuvers for wide QRS tachycardia with baseline decremental retrograde conduction patterns. SVTs with aberrancies is possible, but you can easily distinguish by negative HV interval. But also SVTs with pre-excited SVTs like atrial tachycardias or AVNRCs with bystander accessory pathways may play a role. And of course, wide QRS tachycardia with short HV interval, VTs are always a question. So what should we do? We always start with atrial entrainment maneuvers for wide QRS tachycardias, which has short HV interval. With atrial entrainment, we first check if we were able to entrain the ventricles from the atrium. Yes, we did. Then what we check is the QRS morphology. If we see concealed ventricular entrainment by atrial pacing, that means it's most likely an tachycardia using an accessory pathway antegrately, either a bystander or it's a part of a tachycardia. Then the next thing we check the 12th lead surface EG. You can clearly see this concealed ventricular fusion, and also we check the response to the atrial entrainment. A response is ruling out a VT, as also with the concealed fusion rules out the VT. So this kind of tachycardia is probably atriovascular accessory pathway using AVRT using an atriovascular pathway. And also we do ventricular entrainment to rule out pre-excited other kind of tachycardias like pre-excited atrial tachycardia. And AV response also rules out atrial tachycardia, so it's clear that this kind of tachycardia is an AVRT using an atriovascular accessory pathway. Also, we can see the similar responses as all other accessory pathways do. We can advance the atrium by pacing from the ventricle, and when after the diagnosis, the time comes for ablation. We have two targets. It's different than the other atrioventricular accessory pathways because atrial insertion and the ventricular insertions are different than each other. So we need to target one another. We usually prefer atrial insertions. I will explain why. These atrial insertions of this accessory pathways are usually accumulated on the lateral part of the tricuspid annulus. But we can also target the ventricular insertion, but we usually don't. Why? Because the ventricular insertion site is not easy to target due to anatomical reasons. And if you miss the ablate correct point, then you cannot stop the tachycardia, even make it worse because the refractoriness will increase and then the tachycardia can become more incessant. So it's better to target, at least we prefer to target atrial insertion. But again, if you fail to find a good spot, you can target the earliest activity in the right ventricle. What do? We always use steerable sheets for stabilization. And you can clearly see how difficult to stabilize the catheter because the free wall of the tricuspid annulus is very flexible region. And this area for the ventricular insertion site is not also easy because of the trabeculated morphology of the ventricle. So you can get earliest activity here, but maybe it's not the spot that you, if you are using the three-dimensional mapping system, which is good to annotate the earliest signals, but also you should keep in mind that you can be pulling or pushing some trabecles. So it maybe when you go back and start burning, it cannot be the same point that you annotated. So for atrial insertions, we are looking for the Mannheim signals, the accessory pathway signals in the tricuspid annulus. These signals are during the sinus rhythm without pre-excitation. These are the sharp signals like His signals in the tricuspid annular region, but later than the His signal, unless there is a pre-excitation. But when the tachycardia starts, then it's vice versa. Then these accessory pathways first and precedes the QRS. Then the electricity goes to the RV and then to the His region. So it's the opposite. The Mannheim signals precedes His signals during the tachycardia. And we always use a 3D mapping system, not for annotation because the signals, and this like activation map doesn't make sense in this story, but it's good to annotate the correct point because you cannot easily find the same spot again. And this is an example of ablation. So when your catheter jumps, you can go back and find the spot easily. So it's also important to keep in mind that during mapping, these accessory pathways are very sensitive to the mechanical trauma. So you can see the tracing here. This is mapping during the tachycardia. You can see the signals here preceding His signals here. And then with the mechanical trauma, it's an A signal, this accessory pathway signal, and it is not conducted to the ventricular stop. So it's very sensitive to the mechanical trauma. And then there's also the pre-excitation speed. And then these accessory pathways also sensitive to the burning. You can see the automats during RF applications. And after RF, it's also important to pass from atrial side close to the accessory pathway to check if it's still there or not. And usually after accessory pathway ablations, we check with the adenosine. But in this accessory pathways, this test doesn't mean anything because they are always adenosine sensitive. So it doesn't mean you have ablated or just adenosine effect. And as I told you, these accessory pathways are usually on right-sided, but we also, during past years, we observed some left-sided accessory pathways and compare them in each other. There are also some left-sided Mannheim-like accessory pathways which are not conducting retrogradely, only antegradally conducting accessory pathways. They have similar behavior pattern if time comes for signals and propagation patterns. But there are some other differences in our series. So these are short accessory pathways. They are not conducting to the left bundle fascicles or anterior or posterior fascicles. They behave like a shortly conducting accessory pathways. You can see here, this is the negative, means that's the ablation signal is later than the QRS. That means it's somewhere close to the mitral annular region. Accessory pathways are almost always visible in an atrial insertion site. They are always adenosine sensitive, depending on the dose and the way you give. And automaticity can be observed on right-sided accessory PET phase. We never saw automaticity during ablation of the left-sided accessory PET MAHAIMs. So let me conclude. There are some accessory pathways like atriofascicular accessory pathways or right-sided others. They are easy to diagnose because of the reasons I told you. It's really easy to diagnose if you do the EP study carefully, but it's not easy to ablate because of the anatomical reasons. There are some other accessory pathways which I didn't mention because of the time. Within the nodovascular and nodoventricular accessory pathways, they can really be missed if you not pay attention enough. But they are easy to ablate when you diagnose them because you target the earliest ventricular activity, which is usually in the slope pathway region. And fascicular ventricular accessory pathways, these are also pre-excited accessory pathways, but they are always constant pre-excitation with constant HV interval, and they no need to ablate them. So thank you very much for your attention. This is my staff and team. If you ever visit Izmir or interested in trainings about accessory pathway or other, you are always welcome. Thank you very much.